Welcome to another episode of 22 at the Lips. This is the podcast from EMS providers to EMS providers and anybody and everybody in between. I have with me Ben again, no pun intended. We kind of talked to Ben last time about the transitioning from EMT to paramedic, what that entails, what you should prepare for, all those aspects of that big move in your life. Whether you get there or if you want to stay at EMT, that's up to you. But we just gave some tips, tricks, pointers, things like that. Today, I want to talk about End-Tidal digital capnography in EMS. And I will say this from the get go. No offense to my paramedic instructor, I forget the difference between capnography and capnometry. And Ben, if you want to correct me as we go along, I am sorry in advance. Um, but I want to kind of highlight a couple of things. So, one thing that I learned whenever figuring out capnometry, capnography, whatever, number one, is more than just a fancy number on a monitor. It tells you a lot of things about many aspects of what your patient, either their diagnosis is, your differential that you give, how the hemodynamic stability of your patient. It's also a way to assess adequacy of circulation in the lungs because again it's the exchange of carbon dioxide and oxygen in the body, and it also provides an insight into respiratory effectiveness, literally breath by breath, monitor like acute respiratory diseases such as asthma, COPD, bronchitis. In a recent adventure with myself, how well the airway is working in anaphylaxis. So it does a lot of things for a lot of reasons. And then I want to ask you, how does End-Tidal CO2 measure carbon dioxide in the body? And like, what does the waveform mean? What can we look for? Why is it important? Like, what you got?
So, I'm just going to do a full disclosure. I am a full capnography nerd. I mean, and pretty much everything that is ever out there about capnography in pre-hospital EMS needs to be given accolades to Bob Page. I mean, there is no source that you can really read on EMS capnography that is not attributed to Bob Page. So kudos to him for pushing all these things forward. Um, I mean, so if you really think about from a physiological standpoint, the whole concept of Krebs cycle. Okay, so you have oxygen, glucose in aerobic metabolism. You've got adequate circulatory system to push everything around, create metabolism. Then CO2 is a byproduct of that chemical reaction. Okay, just in the same kind of relation of your vehicle. You've got plenty of fuel, the glucose, you have a good clean air intake, your air filter bringing in oxygen, and then it creates combustion, and then that gas comes out your exhaust. Well, the difference being of, some people might think of your exhaust as the backside, but really your exhaust is your mouth. Okay, so our mouth is the tailpipe of a vehicle. So we are able to measure how much or how effective that aerobic metabolism is just by capnometry is the measurement of carbon dioxide coming out of our body. Capnography is putting it into a picture and evaluating everything. So that capnography and capnometry, the whole process of it is an extremely valuable tool for us, for one of diagnostics and of false negative readings, such as in like that VQ mismatch concept. So where capnometry is not accurately reading for us on as capnography, we can actually use that false negative or false positive or negative positive, backwards on that now. But anyways, the inaccurate reading of that, we can actually use that as an assessment tool just by understanding. But we also need to understand that that is a supplemental tool. That is not a one-handed diagnostic thing. That, all correlates into, pulse oximetry reading, the pleth on your pulse oximetry, um, the qualitative and quantitative measurements of your capnography, overall perfusion status, any underlying medical condition, lung sounds. It's just another thing to help with our differential diagnoses of kind of what's going on, to think very critically and clinically about the presentation of our patient. Um, so you want to just talk about just keep ranting and raving about waveforms and this and that, or
Go ahead, my guy. Like that's what the only big things that I have are for like what helped establish End-Tidal, carbon dioxide, stuff like that. The measurements is that the carbon dioxide, kind of like you said, the exhaust pipe and all that, it's just the product of metabolism that's transported via perfusion and expelled through ventilation. And like I know that's a mouthful, but like that's what helped me establish the understanding of it. So for me, it's the understanding that end-tidal carbon dioxide waveforms, like the monitoring, kind of like you said, it's just another tool to add to it, but it's also like measuring all three simultaneously, like the lung sounds, the pulse ox, your patient status, and like hemodynamic stability, and literally something I kind of went through in there, like looking at them and assessing them, even though all the numbers look beautiful. For me, my oxygen level can be at 100%, but I know I'm still not able to, like, during anaphylaxis, like my airway is tightening, like if that makes sense. So it's kind of just like making the most out of the vital signs that you have, but adding something else in the mix.
sure, that gives me plenty. I can rant and rave on capnography for hours. So if I start getting in any weird side wormholes, just do that number or something, right?
Um,
Uh,
I
look,
want to
it's
go
great about
into
the way that capnography is working is trying to create this visual that your alveoli is a boat dock. The blood cells are passing by that boat dock, and you are the oxygen molecule. You walk out to the boat dock, you wait for the boat to come up. The passengers that are currently on the boat dock is those products of waste, CO2. So you and the CO2, you kind of high five each other as you pass by. You get on the boat, they get off, and then they should be leaving back, crossing an alveolar membrane, going up through our bronchioles, out through our bronchi, and we exhale them. Okay, so then we started thinking about concepts of, let's say pulse oximetry. It's a great tool, but it can be skewed as well as many other vitals. So you go and read that your pulse oximetry reads, great numbers. It says 100%. Well, the way that um, that it reads that is with that infrared light, it's looking to see how much of that blood cell is saturated with something. Unless your devices have the ability to really differentiate between whether that's an oxygen molecule or if it's say carbon monoxide, it could be skewed. And research in this is slightly limited. I've only found a couple publications on this, but one thing that we will find is you have these patients who are they retain CO2 from chronic respiratory failure. That will skew your pulse ox. If you retain so much CO2, your pulse ox is going to read great, but there's going to be a great variance between that and their ABG. So you can listen to the lung sounds, they sound like garbage, and you put them on the pulse ox and it reads 98%, like, oh, they're breathing fine and they're tripoding, they got the duck face, they're not making a selfie, like, oh, they're fine. It's 98%. They don't need any oxygen. But then you could go and put them on capnography and their end tidal might be 80, 90, 100. seen that personally several times with several patients where the pulse ox looks great, the pleth on their pulse ox is fine, good readings there, but then you put them on End-Tidal, and it's like, whoa, their End-Tidal is through the roof. They're extremely hypercapnic. So a good evaluation just to kind of evaluate a multitude of things in there. Okay, so then we can go look at numbers. If their numbers are starting to creep up, that can be indicative that they are retaining CO2, that they're going into respiratory failure, that they're not able to, unload and offload that boat as they should. Okay, so maybe that diaphragm is getting kind of weak. So it's not able to get enough oxygen down in the alveoli. But when we're exhaling, stuff's kind of offloading off the boat, all the extra because the boat's overflowing. So you're not getting enough oxygen in to dilute really all of those. So you're starting to retain CO2 and it's building up. We can use that for such things as maintaining ventilatory status, say in our metabolic acidosis. So, like DKA, you got this patient who's breathing 40 times a minute. Well, we know in basic capnography, if you hyperventilate, you're going to blow off, as they say, CO2. So you're going to have a low CO2 reading. But knowing those things about VQ mismatch, like, okay, they're breathing too fast, they're blowing off all their CO2. That's not really probably what their blood gas is going to show. But we see that low end-tidal CO2 from hyperventilation. So now we got that DKA patient, glucometers reading high, hello, and they're breathing 40 times a minute, their end-tidal's 12. And then we start seeing like, oh, okay, wow, I see they're entitled. It's coming up now. It's 18, it's 20, it's 25. Great. And then you look and that patient's doing the head bob. They're using every accessory muscle they can. Well, that was their baseline at, that low end title of 12, 15. That's where they needed to be for, their body to buffer appropriately. So if we need to assist their ventilations, hey, we take them back to that number because their body was able to measure out everything far better than we can. So we're going to hyperventilate them. I know that's maybe a bad word, but we're going to ventilate them back to maintain what the original baseline was. So again, we can kind of use that as a skew. And another example, we use it in trauma patients to determine perfusion. I mean, and this is such a big thing that's coming out in the past few years about, permissive, well, not past few years, long time, permissive hypotension and really what hypoperfusion is. Well, if we go and look at this trauma patient who's, lost any substantial amount of blood, um, their blood pressure's say 104 over 70, heart rate's 110. Like, oh, 104, that's fine because that's not classified as hypotension. But then you go and put them on capnography, and then you see their end title's 30. But then thinking about VQ mismatch, like, okay, well, ventilation is fine. They're breathing, 20 times a minute. They're not hyperventilating to cause that low end tidal CO2. So then we look at the Q side of VQ mismatch. So now we realize that, hey, their end title's probably low because their alveoli are hypoperfusing. So now we start thinking about more physiology of, okay, alveoli are hypoperfusing, so there's cellular hypoperfusion happening. Even though we don't see any large outward signs of this, by that we can tell the patient is in anaerobic metabolism because of the lack of perfusion to those alveoli because, hey, we use our VQ mismatch. We started doing our little critical thinking in our head and realizing, hey, ventilating is okay. Why is end tidal low? So then we use the hypocapnia to try to do a differential diagnosis of the cause of that and just kind of put all those pieces together. So, like, hey, maybe this patient would benefit from a little bit of a small fluid challenge to get up some systemic vascular resistance or indicative of, hey, this patient is borderline going into decompensated shock. So we can use that whether, hey, do they need to go to a trauma center or do we need to get them someplace quick just to get some blood and get things going? Um, I remember it was probably 6 or 7 years ago. Had a guy, domestic, got shot by his girlfriend in the hand, nothing crazy. And vitals were, as I said, borderline low blood pressure, but End-Tidal was low. Like, oh, he's lost more blood than we thought. And just time kind of went on, small fluid challenge, got a little bit of more volume in there, and it started creating a little bit more, vascular resistance, circulating all those blood cells a little bit better, and then End-Tidal came up. And I don't mean that to be on this caveat of, we'll just give all your trauma patients fluid boluses, because we all know what that does, and don't want to go down that wormhole, but it helped to allow that circulation of waste and body's natural buffering systems to occur as they should. So, like 300-400 mLs of fluid, got perfusion going back, heart rate came down, End-Tidal came up, solid stuff. Then, if we want to go and look at like the waveforms of everything, so if you were to imagine that waveform, if it goes up real quick, straight up, that means that basically all the CO2 in your body has, boom, come out right now. If it's coming up as a gradual curve, as that shark fin, that means that the volume of air you're exhaling, because if you have volume of gases that we're exhaling, CO2 is in that same volume. So if it's slowly detecting CO2 coming out, that means there's an issue with the exhalation process. Okay, so that's going to be indicative of our bronchospasms, air trapping coming out, because he says you probably experienced in your anaphylaxis. The big issue is a lot of times getting the air out because it's trapped inside and we can't exhale. So if your air's trapped inside, it can't get out. That's why it's hard to breathe, because your lungs are full. Okay, so now we see that slow exhalation of CO2, and we know, hey, exhalation phase is the issue. So we get that classic shark fin appearance on our capnography, and we know, hey, we listen to lung sounds that, oh, yep, we've got wheezing, correlates with that. We've got a, relative history, or hey, maybe we don't hear any lung sounds at all. We can't really figure out what's going on, and then we see that shark fin. Oh, yep, that's a diagnostic tool. Absent lung sounds, shark fin, probably in status asthmaticus or significant bronchospasming, and going to escalate things a little bit more. And then one of the biggest things, and one of the real first places we were seeing capnography used, is confirmation of endotracheal intubation or advanced airway placement. Like, that was the gold standard of originally why it came out, to confirm as another device that you were getting a direct reading from CO2, meaning that, hey, your tube's in the lungs, you're getting gases there. No CO2 comes out of the belly. So if you're in the lungs, you've got a reading. Like, okay, cool, we got a number. Like the old colorimetric devices. Barney's bad, Big Bird's good. It changed colors, and yeah, cool. That just is the confirmation tool. Those things are junk. If you have those, throw them away. It's 2023. It's time to use technology. If you got those, trash them. Anytime I see them, I immediately throw them in the dumpsters. Biggest piece of garbage on the ambulance. Okay, so throw them in the trash. Use your technology. Great stuff. Okay, so now we're using those to confirm that, and now we can use it for, it's counting our respirations. The only kicker is that we're not getting total, like, tidal volume measurements out of that, which I'm sure in my lifetime we're going to see that too. There is some tools and gadgets out now, but that's a whole different podcast. Okay, so now we can see that, hey, we're maintaining the certain End-Tidal range, and predominantly the people we intubates in cardiac arrest. So we can use that for evaluation of resuscitation. All right, so AHA's gold standard is End-Tidal minimum of 10 to ensure adequate CPR is being performed. But that's super low, but that lets you know that there is a huge VQ mismatch. Perfusion is shit, so nothing's getting to the alveoli. But now they kind of upped as like, ideally, like 15 to 20 is good, your minimum of 10. So now we see that 15 ish, like, okay, we're doing good CPR. With it being instantaneous feedback, you can look. If you're that crew leader, you can look over End-Tidal's 15, 18, sweet. That person pumping on the chest or the mechanical device you got is doing its job. But now all of a sudden you notice, oh, we're at 9, 10. Like what happened? Tube's good, not a compromise there. But then you look, the person doing compressions has got sweat beating off their face. They're pooped. It's time to rotate out. They're not doing adequate compressions. Or, hey, maybe the plunger on your Lucas device slipped out of location a little bit. And it just kind of one of those things that helps you also. And then the big thing, you're seeing that 15, 18, and now all of a sudden you see your end title spike to 60, 70, 80. And it's like, woo, we got him back. Guaranteed. It's there. But now the kicker to that is that does not always occur. That will occur whenever there is a VQ mismatch. But if there is a very short downtime, and probably a lot of listeners have seen this, it's a quick cardiac arrest. You get them intubated, you put them on capnography, and it's like, holy cow, it's 40. That's weird. That's indicative of a short downtime. Perfusion has still occurred. So when you're doing CPR, metabolism is kind of still going. Now, where we talked a little bit ago about like the shock management, if there is slight anaerobic metabolism, that End-Tidal is going to be low as it would correlate with their ABG. So now you're working that arrest, you intubate them, you slap the cap, and it's at 40. You're like, well, this doesn't make any sense. They're generally only at like 10 or 12. So indicative again of short downtime, slight anaerobic metabolism. And then what you might see is a very minimal increase. So depending on how far that anaerobic metabolism is happening is going to kind of correlate to how much of a jump it takes. So we're talking like if their end titles within semi or close normal parameters of 35 to 45, you might see that jump from 40 to 44. And that could be your spike in End-Tidal when you get resuscitation. So don't expect resuscitation to equate to a huge double, triple End-Tidal reading. It's an increase, a sudden increase in your End-Tidal, whether that's 1 or 50. Keeping an eye on that. And then, that's why the fundamental things are still there about rhythm checks, pulse checks, so on, and good crew resource management.
No, exactly. And you brought up every single point that I was going to say, but I do want to point out one that I'm not going to say you missed, but one that I kind of have near and dear to my heart, and one that I use exclusively um, for sepsis, because you
Yes.
have your low entitled levels that correlate with the elevated lactate levels and kind of predict the mortality in your patients with suspected sepsis and severe sepsis and septic shock, because you're able, like we've kind of talked about, that real time, seeing those numbers, seeing what they mean, and understanding it's not just a number, understanding like exactly, like you said, like the anatomy and physiology of what's happening in real time in that moment with your end-tidal CO2.
Oh, absolutely. And with that lactic acid, that equates to, cellular hypoperfusion. So lactic acid creates, hyperperfusion to the alveoli. So another great indicator. They're fevered, the blood pressure is marginal, but could still be okay. But then their end tidal is junk. So it's super low. And, the ability to measure pre-hospital lactates is very few and far between, at least in the US. So yeah, a very excellent diagnostic tool now. Like every place that has, sepsis protocols or standards, that's the big thing is, what's their, trying to get axillary, orillary, or, rectal temperatures, and what is their end tidal reading? Then that, boom, if you are fevered with a low end tidal, you have sepsis, and you're going to treat it accordingly. Large fluid boluses to create to kind of enhance buffer systems, and get all the crud washed out of you the best that you can. Because if that hyperperfusion of the alveoli increases, that's where we're starting to see, we're not starting, I should say, but like even in instances of patients with pneumonia, you see that low capnography reading, the alveoli are hypoperfused. If alveoli are hyperperfused, super sensitive tissue. So that can result in, atelectasis and then cases of ARDS, where those alveoli and sections of lungs are starting to die because they're not getting any blood flow.
Absolutely. And I kind of want to leave off on one last little tidbit from myself. Um, you've got the everything in EMS has like some kind of mnemonic. I don't know why things are color coded. Things have mnemonics, I guess, just to help us. Sometimes we just can't think straight, especially if you get that call at 2 o'clock in the morning. It sure does help to have the 12 lead wires colored. Um, that's just me. But I have a mnemonic for your digital capnometry, and it's PQRS. Easy. You've got P for proper, making sure that you have your normal readings for your quantity, your rate, shape, and trending End-Tidal, because it's not just seeing the one number, the one vital sign pool, but it's watching what's happening. So for me, it's understanding that like your normal versus what is not normal. What is a normal shape? What is a normal range? What is normal versus that way you can understand what's abnormal. Your quantity. So kind of the same idea, like your target End-Tidal value that you want. You have your R, which is the rate of ventilation based on an age range and your respiratory rate of your differential that's going on. Because something that we didn't bring up, but it rings true, like your pediatrics have a different respiratory rate than I do, or your geriatrics, or even your OB patients. Everybody's got a different kind of range. So understanding like the rate of ventilation for your patient. And then lastly, I would say it's more of the one important aspects, the S of our PQRS. It's the shape. Understanding kind of like what Ben said, what the uptick means, what the shark fin means versus your plateau versus what does it mean to inhale and exhale. And I highly recommend, I'm not going to say waste your equipment, but it sure is beneficial to use your end-tidal nasal cannula and kind of breathe in and out for yourself, hyperventilate yourself, don't pass out, but use that hyperventilation aspect. Hold your breath, watch what it physically does on the screen. Because for me, I'm way too visual, and it's the only way I actually understood what goes on. So that's just me. Ben, if you want to add anything to any of that.
Yeah, and I think of it's important to know like how it's working and what the numbers mean as to when you think it's not working, of like kind of troubleshooting it. So some of the big things that you can see, and you brought it up in pediatrics, is if you are at the point where you use like the child's so small you're using an uncuffed tube, which kind of the HA things change of saying that hey, you can use cuffed tubes on everybody. It's cool. But if you're not using a cuffed tube, that almost kind of creates a can be an air leak. So the way capnography is working is it creates a vacuum, is pulling a small amount of air out of that um, capnogram that's attached to the cuff of your tube. So it's pulling a little bit of air. So if that tube in your pediatric is so small, it may have false readings. From one, an uncuffed tube doesn't create a seal. So for that thing to kind of pull a vacuum may not work well. So if you think about how small the hose is that goes from your cap into your monitor, if that is correlating to a very small, like 2.5 or 3.0 ET tube, there's not much difference there. So there may not be a lot of CO2 in that small tube for your capnogram to create a vacuum and pull it in. So in his pediatrics uncuffed tubes, you might see a number pop up, then go away, pop up, go away. A lot of people think, well, my number went away, I lost the tube, and they try to start all over and pull the tube and intubate. Like it's in there. Still rely on our basics. Listen to lung sounds, rise and fall of the chest, condensation in the tube, resistance, compliance, all those things. Like the basic fundamental things still apply. So anytime you got an issue, start as your patient, work back towards the equipment. Um, Other things, knowing that if we have a patient who has hypercapnia, like oxygen is great for them because oxygen, punches CO2 in the face and tells you to get out of my way. So oxygen comes in, it helps rid of hypercapnic states in our body. So if you have one of these side stream devices, the ones that measure your exhalation by the little nasal prongs and a little hood that goes over your mouth, if you're also using that as oxygen delivery, it's going to skew your numbers. Okay, so you've got the way those work is it's taking a reading out through one side of the nose and blowing oxygen in through the other. So as oxygen's blowing through, it's going to start trying to pull some of the oxygen back through, and it's going to make it look like they're hypocapnic possibly. So again, we use that for trending. Say we're giving them, a nebulizer treatment, measuring End-Tidal through their nose, and we see that their End-Tidal's low, like it was, 30 before, and now we gave them oxygen, it's 28. Like, oh my God, they're getting worse. Like, no, you're just flowing oxygen. And since it is an instantaneous reading, turn oxygen off for 5 seconds, let them take a good breath in their nose, blow it out their mouth, get a good reading, turn oxygen back on if you want to trend. Um, Other ways of using CPAP. CPAP is probably the most useful airway device that's on an ambulance. All right, so connecting those, you can use the same cap that you put on the end of your ET tube or your advanced airway and put it in line. You can conjure it up and make it fit. But the most definite, most accurate way to be measuring capnography while they're on CPAP is use the capnogram through the nasal. So use that side stream one on the nose, mask over that, free to seal, and that's what's going to give you your trend. But then again, remember, there's that capnogram is under that sealed mask. There's a large pocket of, generally 100% oxygen in there. And your quantitative measurement is going to be a little bit low. But again, we're looking for that trend, looking at the numbers increasing up to within a normal range and improvement in the qualitative measurements of that plateau or reducing the shark fin and so on.
Absolutely. And my guy, you've covered way more than I even knew about. I've learned a lot. If there's anything else you want to add, I'm kind of speechless at this point. So it's a lot of information, but it is crucial to know this information. It is crucial to be able to learn this and use it effectively in the field because it's not just something you can document, something that shows like, oh, I know how to do this thing, but it is something that is crucial for your patients who meet this criteria. So then if you have anything else to add, I got nothing.
Uh, no, and I'll tell you, like I am a capnography nerd, and the reason is when I went through medic class at our end evaluations, I had took an exam that said airway was my weakest subject, and I just made myself get comfortable with things I was uncomfortable with and just pounded out airway. But then later found out that my airway exam was graded incorrectly. So actually, I was really good at airway. Just feel like I got better at it. So I just made myself become comfortable with what I wasn't comfortable with. Time when I went through capnography was taught of slap the cap to confirm your intubation, and that was it. We didn't really know what the numbers meant, so and realized that there was a big discrepancy in it, and started learning about it, and then just went full nerd mode and just read lots of research, lots of my own testing, and just started putting capnography on a bunch of patients and kind of figuring out some cool stuff.
Absolutely. So with all of that, That's all I got. Ben, you wowed me. I'll just say that. Like, I love airway, I love pulmonary, but this I'm definitely gonna carry this with me. I'll probably re-listen to this episode about 20 times till I finally get it through my thick head. But Ben, if that's all you got, that's all I got. And we'll wrap it up how we wrap up every single episode. So with that,
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.